master's degree in bioethics, as does Chaplain Bain, and we're also undergoing the certification for healthcare ethics consultation right now with the Harvard group. So we're here to be really your subject matter expert as well as your resource to use for those ethics consults that being had. So we're really thrilled to be in that role. So yeah, I'm going to keep this up.
Well, thank you so much for taking a few moments out of your busy day. I realize there's many things you could do over the lunch break, but we're glad you came here to listen to us talk about ethics. It is something we are extremely passionate about, and after speaking with some of you, you are also extremely passionate about ethics. And during our time here this morning, we do have a couple objectives. You know, we need to have a couple takeaways. One is looking, just having an awareness of the 4 principles of medical ethics. So we'll hit on that. And then the other takeaway is being able to identify the ethical issues within any given situation. And we're going to begin because I'm guessing you've all heard about medical ethics at some time in your professional career. Now, I was at one seminar back in the fall, and this question came up, and everyone in the room said, yes, they've been through medical ethics classes. And then the presenter asked, when did that take place? And everyone said, back in medical school. And once they got into actively providing medical care, they kind of left the ethics in the background. So we're going to start by jogging your memory and going right into a particular case study, and Ms. Herrick will lead that. And then after that, a little bit of awareness. Then we're going to start at the Hippocratic Oath and take a brief run through about 15 to 2,500 years to get to the development of medical ethics that we know in Western medical care, and that are the 4 principles that have been guiding medical ethics in America for about the last 40 years. So I'm handing over to Ms. Herrick, and she will move us into the first case.
Okay, please. A woman enters the emergency room with stomach pain. CT scan diagnoses her with an abdominal aortic aneurysm. Physicians inform her surgery is the only solution. The chance of survival is 50-50. Decision is needed immediately. The woman is a model for a career, worried about scarring and the impact on her work. She refuses the surgical treatment. Physicians persist. She adamantly refuses surgery. Physicians, feeling she is not in the right state of mind, anesthetize her, surgically repair the aneurysm. She survives and sues the hospital for millions of dollars. Okay, so let's talk about what some of the ethical concepts might be that you see initially as you look at this case. What might be some of the ethics issues that it raises? Let's do that. Do you have one? Oh,
they assume she was hysterical.
They assume she's hysterical. Okay. The state of mind issue. Is there a competence or a ability to make a decision effectively? Yes.
Autonomy.
Autonomy, absolutely. The right to choose her own body and choices. What else? What else is some other issues here?
You said the competence issue, but that's not for a provider. That's like a legal determination.
Right? Yep.
You would be consulting the wrong people to make a decision.
Okay. Okay. What else?
No consent.
Consent? Absolutely. Consent. It does bring in the aspect of how someone, you're always afraid that someone might just sue us for something.
You want to get help in the situation. You want to ask people, the expert for getting out of this case.
Right, right.
Stuck.
Yeah, so having that narrow, only one way of looking at something, rather than looking at the numerous possible options there might be. Okay? Yes?
I think the acuity of her condition compresses the timeline so much that it makes a deep dive on the ethical challenges here very, very difficult, if not possible, to execute. I mean,
absolutely. So it's an emergency room situation, right? And so that does change the way we look at ethical decision making and the availability to call in that consult, perhaps. Absolutely. The time pressure. Yes.
Paternalism.
Absolutely. That's right. That is basically they're saying that that's the only solution, and the chance of survival is very dire as well. So let's think about that. Let's talk about that a little bit more. So if we know, clinically speaking, this is the only option, do we let the patient make the decision not to have it? Is that possible? Who has a thought on that? If so, why? Who said yes?
You said, do you let the patient make the decision?
Do you let the patient make the decision to refuse to have the surgery at whatsoever. And because,
Her choice or mine.
great. So you see how this raises a bunch of, like, is there a clear answer? And that's what ethics is all about, is the ability to sort of stop and say, let's look at all the different situational, factors, and then be able to sit and take apart all those different components. So we're going to look at what the basic ways to look at this and begin to try to do that are the 4 concepts. So let's go ahead and look at 4 pillars.
Oh, you did an excellent job, but let's jog your memory a little bit further. Okay, so the 4 principles of medical ethics from a Western perspective are autonomy, which we touched on in that first scenario. Beneficence, what does that mean? Pardon? Do good.
Patients say in your care.
That would fall under autonomy. Now, beneficence is to do good. And then the flip side of that coin is the word I can't pronounce, non-maleficence. Do no harm. So you've got patient autonomy, the patient controls everything, that you as a provider have sworn, you've taken an oath to do good, you've also sworn not to do bad, and then justice is, pardon?
Equal treatment.
I'm sorry, I'm not hearing well.
Equal treatment.
Equal treatment, yeah, equal treatment, equal distribution of resources, equal types of care, what is available, what's inclusive, what's available for one person should be available for all. That was certainly a challenge coming through the early part of the COVID years. There were lots of discussions about the just ethical use of resources. So, building back to Captain Elmore's brief re-engagement with Hippocrates, realizing that the present medical oaths that are taken do not follow Hippocrates word for word, but there are a number of main concepts that he spoke about in the 4th century BC that cross time and that are still incorporated within our medical oaths. Let's get the first line, but keep patients from harm and injustice. So we got non-maleficence, we got justice in there. Never give a deadly drug to anybody. I will visit for the benefit of the sick, remaining free of all mischief and sexual relationships. So there's a lot of items that he identified that many years ago that still speak to the care that we provide presently. So our medical oaths are based upon this, but they're not exactly worded the same way. But we're going to jump forward just a few centuries to get to a few items or events that took place in the 20th century that greatly form our understanding of Western medical ethics. And we are almost always drawn to World War II and what took place in some of the concentration camps. Many of us are probably very familiar with Dr. Joseph Mengele, the Angel of Death, and the horrible research he conducted on prisoners of war during World War II. And then following what had taken place, and there was then the Nuremberg trial, and then many of these individuals that were engaged in this practice were convicted of war crimes, and then from the Nuremberg trial comes the Nuremberg Code. And that helps detail or define what is an ethical way to treat patients and to conduct research on humans. So we go from Hippocrates, we go to the Nuremberg Code, and it doesn't really end there because we jump into the United States because there are 2 specific events that are historical in our country. One was taking place at the same time as World War II, which is the Tuskegee research. And it's kind of difficult to call that a research study if you're familiar with what took place. There was a population of men who tested positive for syphilis, and they were monitored for decades. They were never given the actual cure for the disease, even after it had been discovered. And this continued up until the 70s. And from that incident, then also, Willowbrook is not as well known, but it had an impact. That this went from 56 to 71. It was a study of viral hepatitis at Willowbrook State School for children with mental retardation in New York. Children were intentionally infected with the live hepatitis to develop a vaccine. And what was really if that wasn't unethical enough, The parents were coerced that the only way their children would receive any treatment for their behavioral or retardation issues was to enroll them in this program and then become human test subjects for developing a hepatitis vaccine. So from these two events, in conjunction with what's in the Nuremberg Code, it rolls into this presidential commission to study this. And out of that comes the Belmont Report. Now, I am compressing a lot of years very quickly. The Belmont Report, this comes from that commission, and it's published in '79, and it focuses mainly on research ethics. What is the ethical way to conduct research on human subjects? And that is published in '79. And then in '80, there's two gentlemen, Beecham and Childress. They're kind of known as two of the most important voices in developing medical ethics, and they present these four, which we say are the four principles: autonomy, beneficence, justice, and non-maleficence. And that's compressing about 2,500 years from what Hippocrates said in the 4th century to how we interact in our patient experiences in our present day with these four principles. And there's many other principles that are along that spectrum now and also nested underneath there, especially when it comes to autonomy, because we're talking capacity, we're talking consent, we're talking knowledge. There are many different sub-elements within these principles. And that was a lot of information there.
Yes, but that's fantastic.
All right, so I'll hand it back over to Ms. Herrick.
Yes, perfect. So I wanted to just give you a little bit of statistics on what typically comes up as ethical issues. So we do have patient experience, and in patient experience, many of the patient complaints are around these issues as well. So they kind of tie together very much. If you look at the first one, it's about balancing the quality and efficiency. So just like we were saying, when we're delivering care, we balance the ability to give super high quality, safe care with the ability to get a bunch of people through the system, right? And to be efficient in the way we work. So that's a factor. 70% is about allocating limited resources, medications, tools of support, etc. We do have decision making that we have to make as to whether we can give everybody the same amount of different resources at a given time. Depending on the disease, depending on the challenge that we face, we allocate to certain populations perhaps. Addressing end-of-life issues is a very popular one, common one we see here. Walter Reed is handling that end-of-life phase with those decisions that need to happen at the bedside with families a lot of times. 15% addressing access to care. We know this is critical. This comes up a lot. Do we have processes and procedures to have everybody have equitable access to care? Are there barriers? That's part of ethical care delivery. 15% doctor and patient confidentiality. We're super careful about that, right? But it does come up that occasion that gets breached. There are many times that people are in a public area and things get talked about openly. Being really careful and attentive to the confidentiality of the doctor-patient and all of us as we interact with our patients and beneficiaries. And then 13% about allocating limited organs that are really is a crisis in the U.S. with certain types of organs that we just don't have enough. And we know that we need to be able to decide about where those go as well. So that's a really good overview of the statistics that you see of the most commonly seen requests that we see to get an ethics consult around. And we do them here at Walter Reed. Okay, so here's a case. Let's take a look at this one. Everybody from here. Better? Okay, so, great. Okay, a man was diagnosed with motor neuron disease 5 years ago, the same disease that Stephen Hawking had. This is a condition that destroys motor nerves, making control of movement impossible, while the mind is virtually unaffected. People with motor neuron disease normally die within 4 years of diagnosis from suffocation due to the inability of the respiratory muscles to contract. The man's condition has steadily declined. He's not expected to live through the month. He is worried about the pain that he will face in his final hours. He asks his doctor to give him diamorphine for pain if he begins to suffocate or choke. This will lessen his pain, but it will also hasten his death. About a week later, he falls very ill and is now having trouble breathing. So, what are some of the ethical issues we want to look at as we decide how to support this person in end of life? What are some of the things you see jumping out? Autonomy again, yeah. What else? So he has asked that we give him this pain for at the point he gets to suffocate. So that's his autonomy where he has expressed that, made his wishes known. What else?
Do no harm, but it'll hasten his death.
Okay, yeah. So the balance between, in a way, it's beneficent to offer him that comfort and ease, but at the same time, it's could be seen as from the Hippocratic Oath, performing maleficence, it would be hasten death. Could be seen that way, right? Right? What else? It's not always, it's how you see it. Again, this is always, that's what human beings do. They interpret things based on their own core beliefs as well. Yes?
So can also that drift towards euthanasia?
Absolutely perfect. So is this a euthanasia? Can it drift toward that point where there's a threshold at which it becomes euthanasia? If the dose is a certain level, can you like titrate exactly that moment at which it becomes that? And that's a good point too. It flags people for euthanasia. What else?
He's going to die anyway, so he wants to die comfortably. So if it hastens his death, if he's okay with that, I think that's a consideration.
Okay. So again, it's a form of beneficence to honor this wish that will give him what he believes is going to be a positive thing. Great. Yes. What else? Anybody else? What does it bring up? Now, one thing about ethics is that when we come into an ethics consult, one of the things we have to constantly remind ourselves is we have to set aside our own biases and our own beliefs completely at the door. So how might you identify a personal bias? Is anybody sitting in the room, don't have to say what it is, but is anybody in the room noticing your own personal bias coming up as you think about this? How you personally would do it, how you personally would, and what you think, how you think about this. It's normal to sort of say, oh gosh, how would I get through that? Would I want the same thing? Would I ask for that too? Or, oh, I would never ask for that, and I want to die whenever I'm supposed to die. All these things come up for us as we look at these consultations. As far as the euthanasia thing, I just wanted to share with you, I got the most recent data on what states allow medical aid in dying. Now, this is not medical aid in dying per se. It's not. This is more giving pain medication that may have the effect of hastening death. Actual medical aid in dying is where the person has to identify that they would like to, at this point, be actually given a dose of medication that will end their lives. And in all the states that allow it, it is that they have to actually give themselves the dose of whatever it is that's prescribed. But there are 11 states that allow medical aid in dying. It stopped around 2011. That's where it stopped. I guess the remaining states do not have it, and it hasn't really come up again since then. These are the ones that decided it, and that's it. Now, as far as other countries, there are quite a few that Western European countries that do. Switzerland is a lead in the promotion of this idea, and then New Zealand, Portugal, Canada, Germany, Luxembourg, and a few others. So again, this is a really interesting. I think end-of-life discussion is a really interesting topic. And so let's go to the next slide here. I've actually done a lot of research in my master's program. This is one of my specialty areas of study was end of life. Just wanted to share with you a few things of how end of life people think about it. Okay, so first of all, people's beliefs and feelings about end of life and death and dying, as we call it, are based on a range of complex factors. No doubt about it, right? Religious and spiritual beliefs, a major part. Personality and life outlook. Some people, your personality has a either optimistic look at death, or they have a pessimistic look at death, and that's just part of how we look at things, sort of our personality and the way we look at things as well. Societal and cultural views. We're part of our own culture, our own family culture, our own, the society we're in has the American typical look at death is a death-denying culture. We don't want to talk about death, we don't want to bring up death. It's more of a subversive view of death in our overall American culture, if you can say that. Family members and friends prior deaths. Like if you have stories about people you knew that died in a certain way, or experienced a certain thing at the end of their lives, we either don't want to have it be like that, or do want to have it be like that, or you felt bad that it turned out that way. I have several relatives that went through their end of life where the people around them said, I wish it would have gone that way. There were decisions that got made at the last minute that they would not have supported. So it's a really interesting phase where your other family members and friends can be a story that you tell that influences your decisions or those that you give others. And then evolving physical condition. The condition, as the condition maybe worsens, people maybe change their mind about what they would have wanted at the end of life, because as they face those different physical ailments or challenges or disabling factors, they may say, oopsie, I want to change my advance directive. It's not kind of how I thought it was going to be. So, and you had talked about this earlier about advance directives. Do you want to share that, what you've done? Yeah,
the advance directive I have is through an institute in Erie. My advance directive is actually video recorded. It's on a little, like a thumb drive. I'm sitting there and you take a statement of competency that, I'm not out of my mind as I give this advance directive. So it's kind of an interesting concept. And it's on a little thumb drive at the house. I think my wife's got it.
Yes, the idea of having an advance directive
I'm more, and she was talking about Chat GPT, so I'm.
So having a video recording of yourself and having a really clear message for your family members about how you want this dealt with, is really helpful.
I do want to, and this is all when you have, we're not even talking about those challenges when you don't have consensus in the family.
Yes.
You know, oftentimes.
Yes, very true.
My personal experience has been that usually conflict is the prevailing climate versus consensus.
Absolutely. This is sort of a scene of much conflict around the family and life. It's sad, it's unfortunate because there could be a lot of proactive work that gets done about this, and that's why I like this topic, because we could be really proactive about it if we take it on. Okay, then, this from Callahan. Decisions about this, what you just said. Decisions about desired and appropriate end-of-life care often take place in a rushed, emotionally charged atmosphere. And so that's what we want to be aware of, is to not have that, is to the goal of a family meeting, the patient and multidisciplinary team, to assess factors that matter to the patient, to create the best kind of care. Ideally, and have the ethics
Also,
results
it's
come in.
complicated, the patient doesn't have any advance directives and is comatose or unable to give his
Exactly.
opinion.
That's when it becomes an issue, is when the person's already to the point where they can no longer inform of how they wanted to go. And that's a very common thing that we get called in for, is we don't know, the sister says this, the cousin said that, the neighbor says this, the wife said that, and we have to just sort of look at what the patient would have wanted. Excellent, okay, great, let's go to the next point. Okay,
I got a slightly different one for you.
yeah, okay, yes.
All right, so the previous one had to do with a terminal condition. This one, not so much, but it has to do with care of a child. So how many of you have children? Okay, how many of you feel compelled to provide excellent medical care for your children? Hopefully, all of us. All right, I know this day. Okay, so you're working. You're working in the primary care clinic, and a mother comes into your office with her child who is complaining of flu-like symptoms. That happens, sure. Upon entering the room, you ask the boy to remove his shirt, and you notice a pattern of very distinct bruises on the boy's torso. You ask the mother where the bruises came from, and she tells you that they are from a procedure she performed on him known as, I believe it's pronounced Gao Ya, which is also known as coining. Is anyone familiar with this practice? Could you explain it, or would you like me to?
No, go ahead, but I know you rub a coin on and it's for healing.
Yeah, you put together like this potus, it's kind of like an herbal remedy. You put it on usually the back of the child, and then you rub either with a coin or a spoon parallel and perpendicular to the spine. And it leaves some very distinct marks on the child's back. And it's done under this idea that as you rub the skin and it turns red and even starts to blister a little bit, you're releasing the bad wind or the bad energy from the body, which is causing the illness. And this is very prevalent in Eastern cultures. So this is this practice of coining that you may run into. So that is what is taking place in this. So while it's got that on there, I should put the pictures, but when you touch the boy's back with your stethoscope, he winces in pain from the bruises. I would too. And you debate whether or not you should call Child Protective Services and report the mother. What would you do? I mean, where's the autonomy in this one?
Well, the child's too young.
Oh, I got a hand way in the back.
Yes, sir. In traditional Chinese medicine, they call it spooning.
Okay.
Which you alluded to earlier, and you're absolutely right. It does create welts, and it makes the back super, super red, and it can be very tender, subsequent to the application of it. But it is to, as you were saying, remove humors, but it's often referred to as activating chi, which is part of what we typically use in Eastern medicine.
Okay. All right. Does the child have a say in having this done to them?
No.
Okay. I don't know, I'm not that familiar with the Eastern practice, but I know in our practice we'd be a little concerned if a child came in with these kind of marks on their back, which goes back to what would you do as a provider? What's the ethical way to respond to this, given the dynamics within that family and their cultural practices when it comes to providing treatment? Sir?
The question that comes to my mind, has the child suffered injury?
Okay.
Right.
All right. I realize this is stripped of a lot of details, but from what is covered in this, would you surmise that the child has suffered some sort of injury?
Yes.
Yes.
Yeah, probably, because when he touches back with a stethoscope, he winced in pain. That's probably, well, depending on what temperature you keep your stethoscope, that may not be a normal response to touch that individual. So there's pain. What other areas are concerning from an ethical standpoint as a provider interacting with an adult and a child?
So for us, I think we see it as this mother hurt the child.
Okay.
But from the mother's point of view, this is probably a belief that's been deeply ingrained in her. She absolutely believes it. It's almost probably like part of her soul, her belief, how she sees the world. And it's probably come down through the family and been practiced forever, and this is the way to do it.
Yeah,
So it's a really difficult predicament.
It's a fine line to walk because in her mind, this is beneficence. She's
Yes.
doing good.
Yep.
Sir.
Yeah, I think these are really challenging because I think as a society, most of us believe that there's some sort of autonomy on the part of the parent to
Yes.
decide how they want to raise their child, provided certain lines aren't crossed. And so I think, injury is a relative term. And so, if you had a parent who believed that, I don't know, breaking the child's leg was somehow, part of their treatment, I think we could all agree that, that's probably too far. And so where does that line fall? And I think people may have different opinions. From the sound of this, it would really bother me. And I might consider calling Child Protective Services.
Okay.
That's my own opinion.
All right.
And I understand people may have different ones.
Right, and that's, yes, ma'am.
I think I'm probably, initially I was like, yeah, call. But thinking about other different cultures and how we have a very diverse cultural base here, I think I'd have to take a step back and get the kind of the 5 W's.
Okay.
Really understand why and try to develop a relationship with the parent.
Okay.
Because the other problem is this parent may never come back and you,
Exactly.
you're not going to be able to help the child out of the family.
Right.
How we think from there.
Yeah.
And then I think about, people grew up with whoopings and that was okay until it wasn't okay. And now we
Yes.
have classes to help people not whip their children or beat their children. So, just trying to think, okay, how do we put ourselves in their shoes, understand their perspective, and see is this really intentional that you're trying to cause harm? And if it's not, then how do we change something just enough so you're still getting the humors out without harming the child?
Right.
From our American perspective.
Yes, and I think you bring up a great point because there's other stakeholders' perspectives involved in the care of any patient, but especially with children because we consider them a vulnerable population and we want to do everything we can to protect them. Although, with cultural practices, it does get to be a little bit challenging, and as you pointed out, where's crossing the line from the parent trying to provide quality care from their perspective to being an injurious situation that needs to be reported. But you also bring up a great point. If you make that report, what are the cascading impacts that will have on your relationship in providing care to that family in the future? Yes,
And
ma'am?
also, they may take the mother away from the child, and that could be devastating,
Right, yeah, and there's just so many cascading impacts to decisions we make in clinical settings. And that is something we need to be aware of. And as Ms. Herrick brought up, we also bring our own implicit bias into these encounters also, because as a parent myself, I'd be very much frustrated by seeing this. So there are those challenges that are related. Okay. So when should a physician step in to stop a cultural practice? And we kind of touched on that. Where's that line between providing care and causing harm or an injurious situation? And is there a very well-defined line for that, or is it going to be contextual? And I think Ms. Herrick said this also, sometimes the injury is not physical.
And then why is it okay for us to poke and prod and continuously try to put IVs in and different things into whomever child or and that be not seen as abusive versus this?
Yeah, that's a great perspective to look at, because from their perspective, and you'll see this in some religious practices also, some things that are considered standard care in America are abhorrent to some religious practices, something like transfusions.
Yeah.
You know, and we would say, well, we need this for this individual to live, and they say, nope, it's against my faith. If God wants me to die, I'll die. So that kind of, you're wrestling then once again with some of the cores of the Hippocratic Oath: do good, don't do bad, and then also autonomy. So there's many different. You're getting a great ethical answer. There's no right or wrong. Everything's perspective and contextually driven. And that's part of the challenge. And when you're in an emergency room situation, there's not a lot of time to sit back and call in every possible stakeholder, which goes to what Captain Elmore had started with. You know, what are some of the tools we can have to be able to make those short fused decisions? So we got
You want me to? Yeah.
Sure. I just a quick question to her point. Where's that line though? Like if you're providing treatment to a child, let's say chemotherapy, for example, like, I mean, that does cause a lot of issues down the line, right? Like you can say you're causing harm to an extent,
Yes.
of course, for a greater cause. But where's that line in that situation?
Well, let's dive into the deep end, shall we? It is a great question. Where do you cross the line from being a concerned parent to providing care that's there's a case of Billy Best. Has anyone ever heard of Billy Best? It's not on a slide here, but he would say he was a mature minor, and this was a few years back. He was receiving chemo because he was a pediatric patient with cancer, and at one point the pediatric oncologist decided he needed to have yet another regimen of chemotherapy in order to wipe out the disease. He rebelled and he ran away from the facility where he was inpatient. And the only way he was convinced to come back is his parents agreed that they would not have him undergo any more chemotherapy. So he came back, and he changed his lifestyle completely, and it's decades later, he's still cancer-free. So it's really interesting. Now, when I first heard this, there was another pediatric oncologist in the room who said, well, yeah, but back in those days, we were giving a level of chemo that was up here. And our knowledge says, well, it's more like down here now. So perhaps the earlier treatment solved or cured him, perhaps it didn't. But it ran into that question of when does a minor get to have a say in their health care? And I think that's going to be an ongoing debate forever, because we've got different understandings of an age because children can't consent, they can only assent. And that's based on parental guidance. So it's a great question, and it's difficult to answer. Once again, it's going to go back to each and every situation. It has to be addressed on its own merits and facts.
All right, we're getting into a lot of good stuff here.
Well, let's do another one.
Yeah, let's do it. All right, so let's see. Actually, this is the reduced deck, by the way. We had even more. Okay. So reproductive medical care. This is also another topic of great interest in its own huge subcategory, as you can imagine. There's so many elements of reproductive care. And again, this is where a lot of people's biases will come up and get very easily flagged. So a married couple wishes to have a child. However, the 32-year-old mother knows that she is a carrier for Huntington's disease. HD is a genetic disorder that begins showing signs at anywhere from 35 to 45 years of age. Its symptoms begin with slow loss of muscle control and end in loss of speech, large vessel spasms, disorientation, and emotional outbursts. After 15 to 20 years of symptoms, HD ends in death. HD is a dominant disorder, which means that the child will have a 50% chance of contracting the disorder. Feeling that risking the baby's health would be irresponsible, the couple decides to use in vitro fertilization to fertilize several of the wife's eggs. Several eggs are harvested, and using special technology, only eggs that do not have the defective gene are kept to be fertilized. The physician then fertilizes a single egg and transfers the embryo to the mother. Approximately 9 months later, the couple gives birth to a boy who does not carry the gene for the disorder. Okay, so what do you think about this decision-making process, and what issues does it raise?
It sounds an awful lot like eugenics.
Okay, eugenics, like choosing only the best, whatever,
Right.
fine genetic
Right.
person to have. Yeah. Okay, great. What else? That idea of customizing the genetic profile of a child. What else?
What happened to the unfertilized?
Yeah, absolutely. What happens to the unfertilized eggs? People have different beliefs about those eggs, whether they're human life, whether they're not. All of that comes into play. Do they get discarded? Do they get shared with somebody else? et cetera, et cetera? Do they just get kept for posterity in a frozen state? What else?
I would have questions as to how this technology came to the parents' attention. Like, is this a for-profit, capitalist-driven
Okay.
concern that's, or is this something from a more?
Okay. So where is the profit margin built into this, for example? That's true, there is a
One of the motives of the
for-profit
technology,
initiative.
right.
Yeah, and then insurance coverage, things like that fall into that little category. Does the group pay for the special decision of this person to then do something that they may not all as a group agree? How is it funded? What are the resources? Absolutely. What else? What else is raised for you as you look at it from, if you were part of the person providing the care for this person, what would you be thinking in your head as possible other issues?
You could take the opposite stance, which is beneficence.
Yeah, okay, some people say it's beneficent. We're making sure a person who comes into the world that doesn't have this ultimately down the road diseases they'll have to face. What does that say about the disease though? People with the disease, people who have HD, what does it say about that?
Why didn't they use this technology? Why didn't they use this technology when it was available, right, in future years?
Okay, it could say, and also what does it say about our value system placed around living with HD? Is it inherently a bad thing that someone would be born with something that may be an alternate condition that people without that would have? Is it a horrible thing to be born with a disability of some kind or a congenital malformation? Are we saying this, are we placing a judgment on that? What else? That's right. Anything else?
I think it's like a pro-choice, you know, that I want to have the healthiest baby I can, and the technology's there, I think it's okay.
Okay. So given the technology's there, it's there for use, so why not choose to make that option available? And medical technology, thank you, and if we say medical technology is a form of beneficence, that would be true. Some people say that the world has become too complicated and having options like this is too complicated, and it's a form of actually bad, because now it's making things more complicated and worse for people and humanity. So this is where ethics becomes a very robust topic of exploration and the morass that we enter. And that's why, coming full circle, we go to how do we deal with these things in our day-to-day. So, what do? Do you want to take us to this one? How do we tackle these things?
Well, we look at the
How do we walk out? We have 4 minutes. Go ahead. How do we take all of this? Are you enjoying this? Do you like having these complicated conversations and making your brain work? Yeah.
So we just got a couple minutes. We're going to land the plane smoothly, I hope.
Yes.
All right. So it really comes down to, identify the ethical issues in any given situation that you're interacting when it comes to medical care. If you have to ask if there's an ethical issue, you probably should. If it looks like it is ethical or unethical, you have to ask. And then which principles apply? Because it rarely isn't just one. Rarely. It's usually this intersection of a number of those. And not just principles, there are other aspects of ethics, whether it's virtue-driven or deontologically driven. So from our medical standpoint, we're starting with autonomy, beneficence, non-maleficence, and justice. And really justice tied back into that last one about picking, particular eggs. Because just from a cost standpoint, who actually can afford this type of medical care? So justice does play into that. But then, is there a conflict between principles? And this is one of these tough decision points you get to. Does the decision involve a choice between a good and a bad alternative, or perhaps between two goods or two bads? And that is possible. Not every outcome in medical care is going to be good, which kind of defines what is good, which is difficult because it's always going to be, not always, but usually patient-driven. What is good for them? It may, clinically, this is the right course of action, but for that patient, for that family, this may be what is good in their life. And is this issue more about what is legal or what is most efficient? I used to have a commander say, But we get our Friday safety brief. Any of you remember those? Nothing illegal, immoral, unethical, or unsafe. And you would think we only had to be told that once. But it was every Friday. And as medical providers, I think we have to ask ourselves this when we find ourselves dealing with difficult cases. You know, is it moral? Is it ethical? Is it unsafe? And these are things to keep, you know, on the radar when we get into situations that are ethically challenging. And then, of course, the information slide. So there is this little card, which is a horrible picture because I don't have the card anymore. But there is this phone number that goes to a pager, which, as I understand it, goes to Ms. Herrick's phone. So you will get her. Or you can call her directly. And then I put her email. Then I put mine. So,
I kind of, what do you call it? I triage the ethics questions and consults. So we get about one every few weeks. We have one in the works right now. So we fill up the floors for simple decisions too.
We are available, one of us 24/7.
Yeah.
And because medical issues come up 24/7.
Yes.
So we want to be a resource to help you provide the best care to the patients that are able to read. So pending your questions,
yeah, one more minute.
we will yield our last 60 seconds to Karen.
Let's do that. Sorry, let's do that.
All right, well, we're done.